pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right. Thank you very much for joining us on this cold December day. I hope everyone had a lovely Thanksgiving. If we can have a motion to, well, first of all, I'm going to welcome Dr. Guimont now because it just makes more sense for me to do it. We're excited to have you here. Thank you for joining us. I hope transition has been going well for you. So this is kind of a new location for all of us, so don't feel bad. This is new for everybody here. But we're excited to have you. If everyone has reviewed the minutes from the previous meeting in October, if we can have a motion to approve our October meeting minutes. Second.
Okay, Dr. Boston?
Yes.
Dr. Brunt?
Yes.
Robin?
Yes.
Kathy?
Yes.
Dr. Osama?
Yes.
Terry?
Yes.
Thank you.
Thank you. Our next meeting, gosh, it's hard to believe, will be on January 7th, 2025. Time is going too quickly. And next up is expansion and remodel update.
All right. So we have provided a slideshow.
Oh.
Half video, half pictures. And we slowed it as we just slowed way down. I'm going to try to walk you through it because I realized there was only one room underneath the same. In many cases, you may have been in there too much. So this is just showing the construction walls that they have up right now. That used to be our counter with the kids area over on the side. This is stage 2. So this is just showing all of our directional sites, our new locations down the hall. So Demetrius right now is entering the door that we mostly enter. But that door is no longer going to be there. He is standing in the middle of the vital records office right now. So you'll see that office is all turned up with the new door, and as he turns around, there will be a service window that they've already cut out on the wall. So they will have that service window where they service customers. Provide a records off their separate window, and that's their storage area in there. So as he comes out and looks toward the support staff area, this room is our electrical room, but the only room that remains the same. So now we're walking toward what used to be John and Jeff's office. On that side, and now it's the closet for the IT in the conference room, 2A. And then this whole area is going to be our workroom. So there's going to be cabinetry, there's a copy machine, all kinds of supplies and equipment. So it's going to be great space. So that's that. Now I'm going to walk down toward where my office used to be. And walk down that hallway, and on the left there, sorry, I'll do that. So now you're looking down that hallway, and you're on nursing offices on the left side. And then on the right side, we have, sorry, the left side.
That's just doing little. Do we have the same number of nursing rooms, Gary?
We have more nursing offices, so they're set up. Okay, so here, that's my old office on the left, so that will be an office for 2 nurses. That's the divider between stages 2 and 3. So we're all over on the other side right now. So these will be nursing offices down this hallway on the left. And then on the right, you have a brand new office and our billing specialist will be in there. You guys remember her office used to open out into the living room before? And so she'll be in this space. You can actually stop and look into there.
Yep, it's coming up right here. Right here.
This is actually the hallway. So that hallway goes down into where the clerical staff will be sitting, and the nursing counter and her office was actually before that. So now this is a doorway that separates those offices from our vaccine room and our clinic room. So we can shut that for privacy for patients. And we'll have our new vaccine room here. To the left, and then we made another clinic room right here in the corner. So clinic room 4, and these were existing clinic rooms, so they got longer. restroom over here on the right. And he'll look into that as well, you'd be going walking on the wall for the.
So for anyone who didn't know, they did not have a restroom. So they had to go into the lobby area and all that, and everybody had to. So, yeah, so now we will have our own restroom, which is kind of amazing.
So this was phase one. So this is just showing you how voters was separated and built out for veterans. So this is the veterans waiting space. They have their own waiting space inside their space, and it's so nice. So if you were to enter in there, and I don't believe the coroner's office is available for us to get in there. So this is a veterans space, and then you just walk in there and kind of show you this is all phase one, and they have lots more office space. They have their own kitchenette and break area, and their own conference room in there, so it's really nice. The conference room is up to the and then we are able to in that hall.
That's substantially.
Yeah.
Good for them.
And then on the other side, so. And these are similar finishes to what we'll have in our space as well. So we're really looking forward to it. As it was in my report that stage or phase two is set to wrap up on February 11th, which is 2 weeks ahead of the more accelerated rate. And then we should be all in by May 16th. So we're very excited. So stay tuned. We'll continue to update things like this, and we'll have some kind of ribbon cutting.
So from February to May, will be like where you guys are now?
So yes, from February to May, then we're going to have to shuffle around a little bit more. So we'll have to. The hard part is that there are not very many offices that are being completed in phase two.
Right.
And so we're having to figure, who needs the same bell, how are we gonna configure that? So Vital Records will move over their new space. The sports that will move over their new space. We'll be able to utilize some more room space or some remote working. And we'll just have to figure out how, that I might move into one of the nursing offices for the time being on a temporary basis, and we might need to share the, so we'll have to do something.
Yeah.
It'll be creative, but we are excited and we can do anything. So.
Yeah, good for you.
And we're having a great time. Oh my apologies.
That's it. Very good. I'm excited for all of you. Yes. So next up is new business. We have a presentation from our VU Masters of Public Health candidate right there, Ms. Mariala. We're excited to have you here with us. Thank you.
And all the lessons coming up, if you don't mind, I just want to share that we have had Masters of Public Health students that rotated through over the last year. So we had a student from Grand Canyon University and one from Purdue University. We have an undergrad student that's been with us from DePaul off and on. But last year, Dr. Shane and I actually met with Dr. Lee from Valparaiso University in their School of Public Health, and she asked us if we could work together to place interns. And so we have Velocity and Sunana this semester, and we're going to talk a little bit about, we're going to get to see a little bit of both of their work today. They've done an amazing job, and we'll get to see one of the projects that Velocity has been working on is just kind of looking at our testing positivity rates for STIs across, or in Porter County compared to state of Indiana, plus what we do in the health department. And then she's also been working on some Jamie for bone health at one of the schools requested. So she's going to present that to you now, and then we'll talk about some of the things Suna's been doing and see a little bit of her results.
Excited. Thank you for joining us.
Good evening, everyone. So I'm Scary Nichols. I am Velocity Mariala, and I'm currently working as an intern at Fort Party Health Department. So it is truly an honor to be here today to present my analysis of chlamydia and malaria trends. So this research is not just about understanding the numbers. So it's about recognizing the efforts of our local health department and identifying areas for improvement and contributing to better health outcomes for our community. So let's start with some background. As everybody in the room here knows that gonorrhea and chlamydia are two of the most frequently reported sexually transmitted infections in the United States. but both can have severe health consequences because including infertility and other inflammatory diseases if left untreated. So as these infections are often asymptomatic, so leading to delayed diagnosis and they lead to delayed diagnosis and also increased risk of transmission. So addressing these infections is vital for improving community health and reducing the public health burden. My research sought to address these three main key questions. The first one is, are chlamydia and gonorrhea cases increasing or decreasing in Porter County? The second, how do chlamydia and gonorrhea rates in Porter County compare over time and against Indiana state averages? The third question is, what role do local interventions by the Porter County Health Department play in influencing these trends? So to answer these questions, I analyzed data from multiple sources, including the Porter County Health Department, Indiana State Department of Health, and the CDC. I have calculated prevalence rates for the county and the state for the cases, and positivity rates were derived from the number of positive tests conducted by the health department. So let's start with the chlamydia trends. So as you can see, the Porter County's prevalence rate showed a slight decline from 263.20 per 100,000 in 2019 to 246.38 in 2023. If we compare to Indiana state average, Porter County's rates were consistently much lower. This indicates that our local efforts have helped maintain lower rates than the state's averages. If you look at the positivity rates, which reflect the number of positive cases related to the total tests conducted by the Porter County Health Department, so for chlamydia, positivity rates dropped significantly from 17.46% in 2019 to 7.66% in 2023. Coming to gonorrhea trends, so the prevalence rates in Porter County decreased from 60.37 per 100,000 to 43.91 in 2023. So this is the comparison with Indiana state. Again, the county's rates are much lower than the state average rates. And this is the gonorrhea positivity rates at the health department. You can see that there has been significant decrease from 4.24% to 1.34% during this period. And it's important to note that the total number of tests conducted have been decreased over time from 401 tests in 2019 to 221 tests in 2023. So this decline may partially explain the reduced body positivity rates. So while the findings from this analysis provide valuable insights, it's important to acknowledge the limitations that could affect the interpretation of the results. So some cases likely remain undiagnosed and unreported, especially since both infections are often asymptomatic. So this underreporting may influence the true prevalence rates. And also variation in population size over the years could influence the trends in prevalence rates. And the number of tests conducted by the Porter County Health Department have been significantly reduced, as you have seen in the earlier slide. So this decline could be a reason for the reduction in the positivity rates, as fewer tests might have led to lower positivity rates. And differences also, you can see differences in who gets tested, where the tests are conducted, and how the data is reported over time might also affect the trend analysis. And the disparities between county-wide prevalence rate and the department's positivity rate may suggest that not all residents are using the health department services for STI testing and treatment. So addressing these limitations will strengthen future analysis and enhance our understanding of STI trends in Porter County. So these are the public health implications that I've taken from my analysis. So this shows that while progress has been made, there is a room to improve outreach and access to ensure more people can benefit from the public health department's efforts. So in summary, both infections have shown declining rates. These trends highlight our current public health strategies, including education, testing, and treatment initiatives, that they are working and are also effective. And future research should explore areas like demographics, testing patterns, and community factors to improve the current public health strategies. So here are a few recommendations that I have. So I recommend expanding community screening programs, especially in the underserved areas, and strengthening the education campaigns in schools and community centers to reach the at-risk population would be of great benefit. And also I recommend targeted funding should be focused on increasing community testing centers. This would allow the health department to provide more staff, test kits, and educational materials to meet the community's needs better. And also increasing the access to contraceptive and treatment facilities countywide would be of great improvement. And also, lastly, I recommend enhancing collaborations with schools, healthcare providers, and non-profits to broaden our outreach. So these strategies will ensure we not only maintain our, but also amplify our impact on STI prevention and control. So I believe that together these efforts will not only sustain the progress we have made, but also ensure building a healthier community for everyone.
Very well done.
Thank you.
Thank you. I would personally want to thank my boss, Carrie, and also Jessica. They have helped me a lot through this journey, and I'm really thankful. Thank you so much.
So for their time with us, they spend 150 hours and have to have 2 work products that they turn in at the end of the time, and we have different check-ins. And so the paper presentation that Velocity did is one of the work products, along with the loan presentation that she worked with Jamie on for one of our schools. I requested that. Sunana worked for us on doing a blog on different types of cancer. We share them on Facebook, and so some of the symptoms that you may or may not experience with types of cancer, different types of treatment, cancer preventive lifestyles, screening recommendations, those things. And she also had the opportunity to do some interviews with employees that work for the county who are cancer survivors. And so on the blog, she did an interview with Karen Martin, the author, a breast cancer survivor. And last week, she was able to interview Dan. So Dan is not here tonight. He's our environmental director. Dan has been very open about his journey right now. Today was actually his very last chemo treatment for his colon cancer. And so he got his last treatment today, and he got chemo we all hooked up, and he did it unhooked for the last time on Thursday. And we're gonna all go out and celebrate that actually on Friday the 13th. So Sunana did an interview with Dan. So the full interview is going to be on our Facebook page, but this is a shortened version for you guys to all see tonight, and we're going to offer both of those. In addition to this, she also worked closely with Carrie to prepare the flyers that we sent out to providers about the screening services that we are doing with Women's Health, and also some other things for Carrie to use to create those appointment reminders for patients as well. So, thank you.
Welcome to our Cancer Blog TV. I'm Savannah, the Campus Center for the Health Department, and today we have the privilege of speaking with Dan Dory, who is the Environmental Health Director for the Health Department. will be great for us to make it clear the other second of your journey in their survival and their public health protection. So it's surprising that us right for the first time that you suspect it as such a big might be wrong with your health.
It was beginning of the year, March, early April. I was probably going to put out probably stuff, so I was taking little appointments and stuff. And so that makes a lot. We go to work, we go take into appointments, come back to work, that kind of stuff. And so a lot of people just thought, and the same thing with me was, I was tired. And so we just like, run down for, oh, it's bad, all that kind of stuff. And my sister noticed that I was tired. My dad noticed that I was pale. And so I had my annual checkup with my primary care physician, and I had told him these things and say, he's looking anemic. And so he did some blood work and came back that my hemoglobin was as low as 4.6, so he's 13.7 and 17. So he had told me he needs to go to the hospital and get a blood transfusion to hemoglobin. So that was in April, and while I was there, he said it was some kind of GI bleeding thing before he was scheduled me for to get an upper and lower scanner, scope upper and lower, and you just have to see what's going on. Came back that they had found an acid in my colon. He had marked it during the scope, and then they referred me to a surgeon and an oncologist for 1 year. And that one they were able to hang on this family, friends, so on, which I would say was anything unexpected. But with a big group of people here at the health department, and then family and friends, they all kind of, supporting me behind this and everything. So they helped out. Advices, Gatorade, their colonoscopies that I should have been getting that a long time. Yeah, I put that off. It's just symptoms or you start feeling off or anything. Your physician kind of thought it was just run down from helping my dad. That's how pale I was and everything. They kind of noticed it. If someone brings something to your attention, hey, you're looking so good or something, it kind of hard. They'll just go to the doctor and check out as soon as they can take up these things that are out here to be test things out, figure things out. But sometimes like they want to, it's all around. I'm getting through this at this point, and then hopefully be done, and then it's just screening before then. I don't have side effects from the really.
We want to be able to encourage the family to experience and really respect both about survival and public health protection that will be provided and provided with the psychology.
Awesome. I know. We forgot about the weight loss too. Oh, he lost a. They were on him.
Yeah, to the goal for 16 months lunch.
I can't wait. I know. That's a crazy hemoglobin, right?
Yeah.
With a 4.
You don't get that level out.
Oh, he came and sat down in my office and I'm Googling it and he was on the screen and I was like, I don't know what you want right now.
Yeah. Oh.
Thank you both very, very much. Very much.
For all of your How long have we had this intern process at the health department?
So Sheila started, I remember she asked us, we had somebody approach us about doing a master's public health internship.
Yes.
As supervisors, would you guys,
Be okay.
be willing to help out and have them shadow and what do you guys think? So we were all in. And then when she and I transitioned, she said, well, forget that we were our first intern.
That was the first one, the Grand Canyon.
Yes.
Okay,
Sam
yes.
From Grand Canyon
Yes.
University was our first, and she helped us with our, you guys will remember she was there with us, and we did all of our staff, and took all of the notes and put all of that together for Jan Pierce and helped throughout the process of that. And then Allie was there, who we made the videos from Purdue. She worked on that and also with the Tobacco Coalition and us on a project. And she was blogging about nutrition and fitness. And then Hannah's an undergrad who's local to Valparaiso, and she just reached out and contacted us while looking at this. So she worked there all summer. Last summer, she'll be returning for Christmas break and again this next summer. So
Wow.
she's going to be between undergraduate and grad school. So she's applying to grad schools, and she has many to choose from.
Oh, good for her.
She's
Yeah. Well, and I commend you guys all as well, because it's taking on students is another added responsibility. It's not just they show up and do things. It requires your leadership and your interaction with them, and they've all been so impressive. And I know that you guys have been very integral with that. So just another layer of things that we offer here at the health department, which is very impressive.
and just a lot of nursing.
I know.
Yeah, so it was like 2 schools.
I've seen them come through. Yeah. Yeah. Yes.
And then we getting leaves in the spring.
That's amazing.
And we're nursing here,
Medicine residency programs.
that's awesome.
Yes, yeah. No, and so it's just adds to all the things that you guys incredibly do and they give back to the community. So amazing. Well done, all of you. Okay, so we move on. Any old business to discuss? Okay, so we'll move on to the report of board attorney.
My biggest accomplishment since we last met in October is I managed to only get lost one time in that maze of reconstruction.
Yes.
It is a maze,
It is.
and it just has the potential of giving us so many more tools to do so many more things. I mean, for us old timers, this is really exciting. I remember, in fact, as I worked on the transition with Rod and Dr. Stamp, we have had a health department for 67 years in Porter County. He's our 4th health officer in 67 years. And I think that continuity and that consistency has a lot to do with giving us the base that we need to accomplish all these things that we do. So thank you for your willingness to jump on as number 4.
Yes. It's like a sentence.
Some
You'll
of
never
you-
get out.
Some of you may remember some of these names. There was Jean DeGrazia, okay? There was Gary Babco.
Yeah.
There was Rhea Stamp, and number 4.
Awesome.
That is something.
Whoa.
Lot to live up with.
Yeah.
23 years, is that about right?
Yes, that's the sentence.
I can't
Yes.
believe
Buckle up.
Yes. Yeah.
And Kathy, you've been here.
Well, I came with Dr. Babco.
Oh, really?
Yeah.
Wow.
And she left at one point when we talked her into coming back.
He twisted my arm.
We do those things.
Most of the other things that went on since last we met were the routine things that I and the staff deal with on a regular basis. And that includes unfit for human habitation sites. It involves a whole new, and Dan is working on this extensively, a whole new way of dealing with private sewage disposal systems and how we regulate them. And it did necessitate us going before the Board of County Commissioners for an adjustment in a couple of our fees that we assess, because the ballgame is different now in how we're doing it. And we, after the first of the year, we're going to go back to the commissioners and try to get some adjustments on those. And I think the manifestation of learning lessons is important in life. And we had an incident where there was a structure that wasn't supposed to be, but was in fact being used as a multi-habited structure. And it was not suitable for human habitation. The problem we have is under the law, our ability is to remove people from that environment. But then they sit at the curb in front of the building and get their picture in the newspaper because we're abusing them. And we learned that the hard way a couple of years ago on one that we didn't collaborate and coordinate with the other entities that provide services. And we had one of those this time, and it worked so well it didn't even get in the newspaper. And it involved the city. It involved a couple private charity organizations, the Salvation Army being one of them. It involved the township trustee, the Center Township trustee, and the health department staff, all meeting and coordinating, collaborating, so that when the determination was made that the structure was unfit for human habitation, we were ready this time with a coordinated effort of having first the township trustee and then the Salvation Army find places for these people. I mean, you don't get up in the morning and think, I want to live in this environment.
Right.
Okay.
Of course.
These people have serious problems, and we were able to deal with them in such a fashion this time that I think last time we learned our lessons, and I was proud of the way that Dan and the staff, and we worked with City Hall and we worked with the Township Trustee's office to solve a problem instead of creating another problem by our actions. So congratulations to the staff on that. Other than that, we're closing out 2024, and assuming your lawyer doesn't get lost again in the maze, I'll be there in 2025 to work with the incredible staff that we have. And it's so neat to have mostly money, but it's so neat to have the tools that we need after all the years of not having the tools. And the horizon is just full of potential in terms of what we can accomplish. That's it as far as I'm concerned, unless you've got any questions. No.
Just you.
Did you hear the one about the doctor who went up?
Thanks for doing it. Appreciate it.
It's my pleasure.
It says a lot, the fact that he has been here so long and seen so many different things that he can bring before the board and let you know. And he'll be here long after I leave.
How many more attorneys have we had in 67?
Yeah.
2.
I thought you were the only one. Okay, well, I learned something today.
You remember
Bryce Millings
Oh, really?
was the lawyer for the health department, and when he went on the bench, the governor appointed him as a judge. Then I took over for him
No kidding.
50 years ago. But I was very young at the time.
Yes.
Young and inexperienced and not knowing much about anything.
Simpler times.
But Dr. DeGrazia and Bob Medford, we had John Hilliard, who inspected restaurants, and Bob Medford, who inspected septic systems, Dr. DeGrazia, and Dave Hollenbeck.
That was it? Oh my God. Wow.
They used to issue, they used to issue septic tank and septic system installation permits, not leaving the office of the health department. They had something that were called percolation tests, where the contractor would be trusted to dig a hole and pour water into the hole, and then count how long it took for that water to go away. And that was the basis of whether somebody got a septic system.
Very scientific. Simpler times.
Yeah.
2,000, yeah. Mississippi,
John-
Mississippi.
What's the, right on the main drag there in Hebron, the restaurant?
Oh,
Right. John Hilliard inspected restaurants, and we always knew where John was because he loved their pies.
That helps. Yes, they needed frequent.
How many times we had to tell John? He sat in the front window of the restaurant eating pie.
They got the clean bill of health, so. Awesome. Well, thank you so much. Claims and receipts have made their way around. If everyone is in agreement, if we can have a motion to approve our claims and receipts. Thank you. Thank you.
Dr. Boston,
Yes.
Dr. Brunt,
Yes.
Robin, Dr. Fleming,
Yes.
Kathy,
Yes.
Dr. Rosanna,
Yes.
Terry,
Yes.
thank you.
Thank you all. Up next is our reports of committee staff and health officer again. Thank you for joining us. We're happy to have you here. I don't know if you have any words to start with before we go to our staff. It's been, transition has been good?
Well,
Uneventful?
as good as it can be.
Good.
Every day's a new learning experience.
Well-
So, and I gather a little bit more information, a little more tools, website, thanks Terry. So,
Meeting invites.
Yeah, there's a lot of those.
I didn't have any info today.
Oh, okay.
Yeah, no, it's been fine. Everybody's been great.
Good. I'm glad to hear it. All right, so we have,
Real quick, I just wanted to, I know you guys have a lot of attachments in advance of this meeting. So I just wanted to comment about, the partner reporting that we do from some of the helpers and Indiana things. We're having a hard time getting that to just PDF. And so you got 2 copies of it this month, and the one was the PDF is not complete. So that will now just be a protected Excel document. So when you see that, that'll be Chris's report, and it has the food pantry and diaper, all that information on the first tab, and then there's a second tab that has all the information from the first and it has all the region. So just remember to go to that tab because they do a very nice job of providing a graphic and land stage, and so
it's amazing. I'm so proud of that. I'm so proud of that, what they've done with that funding.
It's an amazing service, so we're really happy about that.
Yes.
So just kind of wanted to point that out. And then Carrie Honeycutt is going to talk just a little bit about the dashboard we've been working on with the GIS. We don't have anything public facing yet, or we would pull it up and show it on here, so that's why she's made the copy, just to kind of show you where it's at and what we can do with this. When we'll start entering in a LIFT program and then all of the other programming that we're doing as well, so that we can create dashboards and get these visualizations. So Carrie, you can wherever you're coming here.
My chair moves, so whatever's you're comfortable with.
It's good for
Guess too that you're in the middle there.
So the first page that I gave you, these are all screenshots. It's not public facing yet. We're still, this is the first dashboard we created. The first is bicycle application program statistics. And then I broke them down by each on the following pages. But I just kind of wanted, because it's hard to see them on one page, where you see housing opportunities, and shelter. Those individuals are also considered homeless, but they have somewhere to stay at housing opportunities or a shelter, but they don't have a home to call their own. And individuals that are homeless truly have nowhere to stay. So that number is a little bit higher. Also felt it was important to indicate how many applications we received compared to how many bicycles we've issued. Some have been denied, whether they have their transportation needs met, they weren't qualified, things like that. And then not issued or closed was interesting to me to find as we went along because they either didn't call me back to set up a bike pickup or even call me back to just go over the application because the bike doesn't get issued just based on the application. I have to have a conversation with them to get a better understanding of their needs, whether we need to provide them with resources. We did have one bicycle returned. she lived on the second floor. The bike couldn't be kept outside. There were some health issues, so she opted to return the bike. But also told her that if her situation changes, to reach back out. So then we passed that bike on to somebody else that needed it. And then as you can see, more males have been provided with bicycles than females. The other part that was in my report is we have indicated on the map, which is part of what GIS is geographical information, and it will show you the green or bikes that were issued, purple. Don't have the legend in front of me, but you can kind of see we are providing bikes mostly in Belleville area, but they are also still spread throughout the county. So it obviously does help individuals more in Belleville with the sidewalks and downtown area and things like that. And then even when I get an application, I also kind of look on Google Maps just to see, are they going to safely be able to ride that bicycle? And we had one individual end up changing her mind because she was afraid of getting hurt, and where she was saying she couldn't probably safely go the bicycle. So then that's just a conversation we have, and maybe I provide her with other options. The total cost of bikes, as this was a new program, I learned along the way that it was really popular, and I wanted for me to track which bike they were getting, the cost per bike, because the cost varied. The helmet and the lock were consistent, and then maybe a basket or a rack on it, but the bicycle cost was different because we had some that were donated, some that were used. We have had to purchase some new bicycles rather than have someone wait months for a donated bike. So that cost isn't quite accurate, but to date we've spent $11,136.22 and have issued 39 bicycles. That total number also does include helmets that we provided during some bicycle events to ensure safety. So we're continuing to we'll update this as we see a need, and then the application is available online, so they can now, rather than do a paper copy, they can fill it out online. I get an email notification, and then I call them, and everything's electronically tracked rather than paper, and there's no place to go to.
We're really excited to see how we can use the GIS system for tracking or other programs and things like that as well, and then also to turn some of those dashboards around to public facing for certain information so that everybody is completely transparent about everything that we're doing and the people that it's impacting and so
I'll just add to the bicycle program spread by word of mouth. So it's spread by the providers that were working with individuals who needed the extra help. We didn't advertise this on social media. A lot of bikes, I had a gentleman I gave a bike 2 weeks prior that brought somebody else he knew in and came in with him, and they sat with them, and so a lot of times they're kind of going through their struggles together. But they set the word organically, how we wanted it to happen, and so it wasn't just, oh, it's a free bike, can I have a free bike? It's been really neat. Someone reached out to me, I got pictures, and then somebody put lights on their bicycle. He stays at one of the shelters and has to ride at night. I'll give them an orange that's to put on. We have those, and so it's been kind of neat. And I see them out and around, as well as Leo, our partner with us.
Very good. Very nice. And I like seeing how spread out this is. Like,
yes. I knew it
really,
was that way, but then
yeah,
it's
it's impressive
here,
to see.
like,
Yeah.
wow, this is really neat.
Yeah, well done.
And then the other thing that I have is, as you know, we've talked about by December the 1st, to the state, we had to turn in what local level KPIs we were going to begin working toward, beginning January of 2025. So last year we had the state level KPIs. The state was working to get a certain number of health departments to provide these core services. And so throughout this year, we've had different times where we had to say where we were at, working toward those different core services of the programming that were set aside for that. So then for 2025, we were tasked with developing at least 3. They encourage us not to go beyond 5 local level KPIs, and they actually provided 7 areas in which they had hoped people would focus. And so these are what we've come up with for 2025. And this was not in what you were emailed because actually we turned it in right before Thanksgiving. But we just got our final kind of approvals by the subject matter experts for the goals being SMART goals, so they were attainable and we were able to measure them, and we have the proper amount of activities toward and things like that. So we'll share these with you. I'm obviously not going to read the slides. Each of them, Jamie prepared these. Thank you so much. And so for each KPI, we chose to do 4 this year, and what we'll do is we'll be able to add to them. Or if we have set to get to a certain goal by 2027, but we get there by 2026, then we can choose to keep this KPI but move the needle a little bit further. And so this is all things that we'll be working and evolving, we'll be adding to as the years go on. So for each one of them, let's our KPI, the activities and our partners on the first slide, and then on the second slide it will list, interesting one, just so we can say, the target population and the data source that we're using. So then the state is going to take all this information for each county, and this will be readily available on our Health for City website. So as you can see, we chose to focus on increasing the immunization rate for accounting for children less than 3 years old completing their required vaccine series. So the 64.3 is where you're at in 2023. We're going to try to get to 66% by 2027. And so I just encourage you guys to look at these, any comments that you have, any suggestions, any partners that we're missing. So we just want to float back to any partners that we're missing or suggested activities that you have. Please let us know. So I will send this off to you guys tomorrow, so that you have time to look through it. So this is how we had to enter into the red cap that we had to enter into for the state. They've approved them all, and like I said, they will turn them into an KPI saying that we're going to do these things by partnering with these people and these activities and using this data source. So, so that was our first KPI. Our second KPI on injury prevention is to decrease the suicide rate. So our suicide rate for last year was 16. This is using our own vital records data, 1,600,000. And our goal would be to decrease it 1,400,000 by 2027. I will say that in October, we hit the number of suicides that we were at the end of 2023. There are several of us that are on the suicide prevention task force, and we have several different efforts in the works right now. So that's something that we would like to focus on going forward.
Carrie, is
Yes.
that adult data, child data, or both?
Oh.
Everything.
So it's combined,
Yes.
age ranges from
I think
15 or 15,
Yeah.
1, 15 to 20, and then up to 90, and then up to 90. Okay.
Yes.
So together, that's the rate.
Yes. I will, majority between 20 and 50 is the biggest fault where we did have, this year that we had, for, in the elderly population with those together, so.
This 2, and last year there were 8 or 7. Because I was just wondering if there are any teen children or adolescents that a partner with these schools.
Yes, I thought so.
I mean, you know, when you think about those folks, the counselors at schools, the teachers, the trusted adults in a child's life,
Yes.
beyond their providers, their parents, their family members, our school. You know, I mean, that's a waste of time to go that.
Absolutely.
So I would add that, if that doesn't include children.
Therapists have a group that, group partner.
I mean, there's a lot of private practices in the area.
I don't think there's like a centralized
There's not centralized.
connecting Border Star is probably our best option.
Yeah.
And then, like HealthLink has mental health. Does North Shore as well? They do, right? Yeah, so maybe those locations as well, because I know they have mental health departments. Yeah,
I mean, if we're thinking about college students,
Yeah.
that's very high
sure.
possibility, so.
Yeah.
Just our population. And we can also move out tomorrow, so anything you guys think of, yeah, suggestions, things like that, should we email that? Next meeting is, so we have two KPIs for chronic disease prevention. So originally, we wanted to decrease the adult physical inactivity, and they got back to us and said, that's an action.
Yeah.
Choose one of the chronic diseases to work on, and we were really nervous because that meal takes a very long time to do. It was very hard to do. And so their suggestion was to go out 5 to 10 years. So that's what we did. We went out 10 years. The 42.6% obesity rate is adults over 20 years old with a BMI between 2018 and 2023. Fort County is at 42.6%. The state of Indiana is at 44%. 40.3% is the national average.
I know. That's not good, yeah.
Yes, that's the national average. And so that's what we are shooting for over that 10-year period of time. We get any suggestions for additional actions.
I guess my challenge is where do you get these numbers? Like, where do you get this?
Yeah, so we just go to the next slide. This data comes from the Indiana Health for Patient Care, IHI, the Indiana Health Information Exchange, and the Industry Institute.
So these are people seeking health care.
Yes.
So
Maybe
the
it's
patient
skewed. Yeah, you know.
charts- Patient charts, I mean, if you cherry pick the new Yara Olympic patients here, look at this style.
No, they're not new. They have to be 3 months.
We'll use the same data source, and this is where they source the data that's used on the Porter scorecard. So this is on, we took this straight from a Porter County scorecard. Can we do a screen in the health codes for it? I mean, just giving people information on what they do.
I think we just did pediatric screens, right? We did pediatric physicals. So yeah. I know. Don't think there's an issue.
Right.
Or that their BMI might be off.
Or what, what. Right.
I think education's a huge component.
I know.
Yeah, I had one today. It was a big ordeal. Yeah. It's hard. It's hard. Yeah.
Address the situation for it to even be dealt with.
You check your blood pressure, right, when you're monitoring the medication, so.
But this has just such a different state.
Oh, yeah.
Yeah.
It just has such a different state.
But do you use compared scales in the office to automatic BMI?
No.
And then maybe even say, hey, we can give you some helpful information on dealing with that for online avenues. People are on their phones all the time, we have that stuff.
I mean, I will tell you, being in primary care, just having gotten back from a conference, an actual conference, there's a push to deep state with high, it's obesity. And that's an actual push as well. So you're talking about trying to stigmatize it, because that, I mean, just by talking about it, technically that's stigmatization from their standpoint. And they're trying to say, well, you know, if your patient doesn't want to step on the scale, don't make them because you're.
Or if they're here for a runny nose, they
Right.
don't want you to talk to them about their weight. But at the same
Exactly.
time, we have this opportunity.
Right.
So it's a very
It's
like
a
narrow
very,
balance
very,
beam
very, very,
to
very
be on,
fine
to
line.
have, yeah. It's hard. It's hard. We have to start somewhere. Yeah.
People want to live long.
Sure.
And that's my issue.
And this is where it starts.
We gotta sometimes bring up those conversations, and most people want to live long and not have money.
I do feel like over the course of the last decade, I have a lot more patients who, due to their insurance or their work provided insurance, they're required to get wellness physicals. And that gives them some sort of financial incentive, or they get taken less taken out of their paycheck, or whatever it may be. And that has given us a lot more opportunity to discuss these types of things, because otherwise people tend to come to us because there's a problem and we're trying to, to solve, to put out this fire, this fire, this fire. We never get to really step back and talk about wellness. And so I think that has been a nice change that I've seen, in patient care, that these wellness things are kind of becoming more pushed upon for them to do in one way or the other, and then we can have these conversations without them coming in for a sore throat or a cough and then say, hey, your weight though. So we have to start somewhere.
Definitely, not many screens, that's a part of it, so inviting some people out there.
Are they doing it as far as the diabetes screen by any chance?
Yes. Yes. And even if, we, partner otherwise, then we can also refer to the Ruby program as well, if we have concern for those factors for that, in addition to that. There's the alliance of knowledge that. Do you have any other suggestions or anything like that? I think getting the information is important. Data.
Yeah, I know you told us, I apologize, I know you told us where the data sources came from and how they collected it is extremely important. So, that's just be.
Yeah, I do age collecting the data, and I guess it lists and you hover over it, what the
Metrics.
so how they got, what metrics are and where it came from, as far as how they get it from these data sources.
Right.
And what all these sources compile together, and that's a good question. We can find out. So in that dashboard, it's updated regularly. And what they'll do is they'll just continue to roll the 5-year. Because that's one of the things I asked. So is it always 2018 to 2023, and then 2024 to 2029? How do you? And they said that it will roll, so it will become 2019 to 2024.
Oh, okay.
2020, yeah, because that was my question.
Yeah. Well, that's important because this isn't going to change overnight.
Right. We just want to say, do it to your level, data source, and then say.
And if you're collecting data from those diabetes screenings, is that a data source? Or is that not?
If we felt that we wanted to use that data solely, we could. I don't think we'll get enough data to be statistically.
You don't mean to have it as a source, or it's not statistically significant with that one?
I don't know if we didn't start with that, we would be able to add it. Not this time around, but if we reset it.
And are we looking like longitudinal, like person A in 2023, same person A in 2025? Because that's very different. That's comparative longitudinal data versus just big data chunks, right? So you don't necessarily know, because not only are we looking to reduce the overall rate, but we're looking to reduce individual change, as Robin was saying, right? So those are two very different ways to look at data, right? Within comparison of person A over time versus group A would be. Those are gonna be different groups of people.
And I don't know 100%.
You know, I would guess. Just for-
Yeah.
okay.
This is a hard thing to collect.
Yeah,
I mean,
that's
this is
hard.
not, there's, you know, this is a challenge. And then I have to assume that the people that they have are people that are going to get healthcare. Maybe there are people who aren't going to getting healthcare because they're healthy, or they're not going to get healthcare because they're not healthy. So where those numbers would drag.
So just, I mean,
It's just
just
a difficult-
mathematically speaking, I did the math real quick. There's about 175,300 people in Porter County. 40% comes out to 70,100. 0.42%, 42% is about 73,200.
Adults.
So you're talking about a move of 3,000 people to try to get out of that category.
Adults.
Well, fair
Yeah,
enough,
yeah.
but
We could do
regardless, I mean, you're talking about a shift of 3,000
It's a lot.
people.
Yeah.
So again, and Jamie and I were talking about this morning, targeting the schools, the adolescents, right? So keeping them from coming.
Yeah.
into
I mean, that's, the prevention is better than the
Yeah.
treatment. Sure. Yeah, 100%.
Yeah, because those are gonna shift.
I would always rather prevent something than having to deal with it after it hits the fan, so.
Because those are the folks that are gonna be shifting into the over 20 group in 2028 to 2030.
True, yeah.
But they want people shifting out, right? So like it will be, you know, those will be the source of the data for the next few years.
We have the ability to run with the school.
Oh, yeah.
Yes.
Full time.
Working on any of this.
We have a plan that we have proposed to one school systems for starting a, school garden initiative. And maybe even doing some swimming to the youth.
I mean, I hate to say it, but nobody knows what, if you don't know you have an issue, how are you supposed to address it? You know, there are schools across the United States that do ice creams and it's very controversial, of course.
Right. Because I mean, the issue is really stems from the parents, right? Who's capable of they're taught at home, so you're not really targeting the kids, you're targeting the parents and the kids. So that does get a little iffy at that point.
But exposure, I think, is important. Like when we were dealing with JDC, you know, they were telling us like these kids at JDC, like they would expose them to fruits and vegetables that they've never had before. Like how would they know like blueberries if they've never been exposed to them and things? So the schools could be a nice intervention point of exposing them to these things, and they can go home and say, "Hey, mom, can you buy this? You know, I like this. You know." Yeah.
Because, I mean, a lot of people don't even have an opportunity to do that, they don't have the, ingredients availability, their parents don't want them.
We're busy. Yeah, working. Yeah.
You know, but like even about having
Sure.
some of this stuff and exploring and trying to like incorporate healthy.
Well, teaching them to eat well and to suggest that is all good and it's fine, but affordability is a big deal, right? For people to put their hand food on the table,
Sure.
$8 or a little thing of food.
Yeah.
You know, a family of 6 or 8 can't do that. So that, you know, kind
Yes.
of stymies us somewhat. So when you talk about prevention, maybe we should be gearing exercise, right? Meaning that it doesn't cost a lot to walk or to move and you know, just burn some of those bad calories.
And that's where we were with the decreasing physical activity, all these ideas, and so now it's just gonna be putting it
Yes,
together.
as an action.
And then it also goes together with the program that we are working on with the food bank. Again, a lot of it's not fresh, but now our goal for this year is to get the fresh into that as well. So working with Tia and we're working with local farmers and providing, learning programs and things like that, so.
Terry, you're right, Florida Health established societies in the world designed by Singapore, Florida. You can walk, great transportation. Most Singaporeans walk 4 in the morning, and most Americans do all day. So it equates to health. But I think going back to mentioning, starting with the pool of patients, people already involved with diabetic, if you think about the office on a daily basis, the majority of those there, typically in regards to the younger population, before problems happen because their parents had the heart attack, are diabetic. So they're in their 36, but it's not from a spouse or a family member. it's their experience on it. Like, the parents had this, so they come in, so we can almost dovetail if we do have a cohort of people for one thing that are meetings, and to guide them to these other programs, so you get people, that's probably a majority of our day. It isn't a 28-year-old coming in, you know, I just thought I'd get a cholesterol.
No,
Because my dad had this, or there's usually a variety of folks, and where they work, offering up something that's the drug all day, and I did 20 wellness exams today, none of them were well.
no.
You know, it's a joke, you really hear it, you know,
I know.
but it gets people, and it starts the conversation, and to try to redirect those groups of people, that people will be more motivated to seek care, go and check their weight, put a baseline and how to move diet. Yeah, the kids.
Yes.
This is a lawyer asking a question, so I apologize to the doctors if it's foolish. But where does medication, I haven't heard that word in fighting obesity and changing lifestyle. As an ignorant person in this area, when I turn on the television, I'm being told that this drug will facilitate you losing weight. And as I'm also told by some people at Lilly, they are on the cusp of some amazing drugs where you don't have to walk or eat the right thing or anything. You take 2 pills in the morning and 2 at night, and voila, you lose 40 pounds. Where is that?
I mean, I think there's a place for this as well, and certainly they're groundbreaking. They're game changers. I think any of us who practice medicine, we can't avoid them. I think they're amazing. But again, like my goal would be to not have to get to that point. But of course, if we're trying to bring those numbers down and for the certain population to where it fits, you know, it's going to help. But you know, I tell people all the time, weight doesn't always equate to good health. And in my education to my patients, I try to always remind them of health. And so being skinny doesn't always mean you're healthy. And so I think we have to always bring it back to that yes, of course, you know, you're probably going to live longer on this planet if you have less weight on your bones. But we want to focus on your overall health, and the weight is just one component of that. And that's how I look at it when I address it with patients.
So I will tell you, I spend the majority of my day speaking about something called the metabolic syndrome, which is obesity, hypertension, diabetes, cholesterol, all wrapped into one. And absolutely, these medications have been game changers. I mean, the fact that pills, which is a big portion of my population, cover these medications has been a gangbusters.
Big time.
To be able to get some of my patients lose weight. That being said, it's not available for everybody, and yet Medicaid doesn't cover it. They definitely don't cover it for weight loss. They don't even cover a lot of these
for diabetes.
without prior
You're right.
So,
or failure on other words.
Right. So at the end of the day, they're wonderful agents, but they are not accessible to everybody. And furthermore, there is a lot of question as to what the long-term success rates of these medications are going to be, whether, you know, there's data with Ozempic that shows that their failure rates half a decade out are pretty high, and that people do gain a lot of weight back even staying on medication. That's actually been shown with even bariatric bypass.
Yes, of course.
That patients 10 years out tend to gain a lot of weight back, even with drastic surgical measures. So at the end of the day, I think one of the big questions, and this has not been answered, and someday once, I think this question needs to be answered by the scientific community, is what's driving the obesity rates. We've had a 30% to a 40% increase in obesity rates in this country in the last 20 years, from 2000 to these rates. I mean, what's driving the underlying needle that's moving the obesity rate? I mean, I think in the 70s we were 10%. So you start talking about what's causing it, we can figure out what the root source of all of it is. And maybe it's not one thing, but the problem is, I think a lot of us doctors are spinning our wheels, because I listen to a podcast, and I know I'm going in circles here, and I apologize, but this is a conversation I spend most of my day talking to my patients about. I listen to a podcast as a primary care physician, chastising us primary care physicians to employ these methods to get our patients skinny. And I appreciate that, because he's saying, you know, we don't have a society that has a lack of Ozempic. We have a society that has a movement problem, a diet problem, a carbohydrate issue, a McDonald's problem. And I agree with that. But here I am staring at a 35-year-old who's LDL of 156, and I'm supposed to sit there, and now I'm talking about putting him on metformin, I'm talking about putting him on cholesterol medications, I'm talking about 3 blood pressure medications with this guy for the rest of his life, or I can put him on this one drug that potentially will reduce his weight and not have to add any of those medications to his list. So to me, that's a no-brainer, and to answer your question, I think that they're phenomenal agents, but I think that the bigger question to the podcaster's point, and I think that the long-term solution to this is figuring out what's driving the obesity rates. I don't know if we're going to do here in Porter County, but if anybody can figure that out, one of two things is going to happen. You're going to save the world, or you're going to end up in a shallow grave outside Las Vegas by the company that's causing it. So, you know.
I guess I just think of it as human nature.
Right.
If I'm told if I take these 2 pills before I go to bed at night, I don't have to worry about my diet.
It's true, though.
Yes.
It's true,
And
but she's
people
right.
like that.
It's just only one part. It is only one part. I mean, I had a guy just today in my office who's BMI is 26, and he's talking about running the October Marathon in Chicago next year as his goal. And I've got him on 4 diabetic medications a day, and he's still 7.5. You know, so I mean, this is not an unhealthy man. So there are genetic components to these things. It's not all just unhealthy lifestyle. There are many factors that go into it. But at the end of the day, yeah, you know, the lifestyle plays a role. The moves. Look, you catch the genetic football on the 5-yard line, you're more likely to get sacked than likely to catch it on the 50-yard line. I mean, that's a big part of this. My dad had a heart attack at 45, and I was staring down the barrel of about a 45 heart attack. For me, luckily, we've had medications to keep me from that. I've, over the past 15 years, been on those medications, but I had a conversation with my family doctor and my cardiologist when I was 30. But the reality is we have better tools. Employing them is important. It's not just the Ozempic, the loophole, it's all of it. So, anyhow, I'll stop talking.
Well, it's a worthy topic for us to focus on. I mean,
It's big.
yeah, it is.
It's easily 50% of my day now.
I agree. It's really, and I at least appreciate that people are coming in and are wanting to have this discussion,
Right.
which has changed. Like that wasn't the case.
Absolutely.
And so I'm taking advantage of that.
100%.
Yeah.
100%.
So, very good.
In that light, you may remember this out on 8094, the billboards. What they said was, obesity is a disease. That's all it said.
But there's one doctor that advertises his weight loss clinic. His science had changed from weight loss the right way to come get Ozempic.
Yes, you are right. I know. Yeah.
You guys all know about it.
Yes. Yes, we do. Yes, we do. Awesome. All right. One more?
Thank you. Yeah, one more. Sorry.
Well, it's a good one.
This is great.
Yes.
This is great.
Yeah.
Really, review and any suggestions you have. The other chronic disease KPI that we have is decrease unrelated ED visits from 23.25 per 10,000 in 2022 to 22 per 10,000 by 2027. These decreased drastically during COVID, so there have been some questions about the actual numbers. And so they encourage us not to go down by too much for our goal, just because they expect to see in some cases.
Okay. I see what you mean.
A lot harder since.
Okay.
So, but as you can see, we have some activities. Jamie is working through, there are a couple of different programs for school-age children that we are offering to schools to come in and do for different age groups, as well as working with our local integrated health program new to Porter County for if they get called out and they're breathing-related things, they can refer to us as well. And we've talked about this a little because we have the capacity building grants, and we are able to, by referrals, go in and do home trigger assessments and education on triggers, and also what individuals on using medications appropriately, things like that. So that is activities and partners for that KPI, as well as the target population and the data source for that data. definition of that.
Like with
Is that-
urgent care
Is
call.
it urgent care, is it hospital, is it freestanding, like what is that is the question.
Like a Midwest Express
Yeah,
or something.
because I'm
Yeah.
saying like that will make a huge difference, because, you know, depending on how you objectively define that variable, that will change the whole outcome.
Hospital discharge date, so I'm going to assume it's probably not.
And that's probably why the number went down, because I
Yeah.
think through COVID, people went to these
Yeah.
different places as opposed to going to the.
Right,
in
and
real
that's
life.
what I'm saying, Robin, like if we're collecting data about asthma emergency department visits, we have to differentiate that from just emergency asthma visits, right? Because two different locations.
I mean, this is definitely emergency department business.
So
This
this
is
is
people
like
go
To the
hospital.
ER, yeah.
But what I don't know is, does that include urgent care? Like,
Yeah.
is this urgent care and ER, is this just?
From how you, when it says data source discharge.
That means hospital.
No, I have a hard time getting those records of my own patients when they follow up with me from those places. I mean, it's like a Fort Knox.
But then does that really though address or really define the chronicity of that disease? Because if people aren't going to the hospital, are they going to the urgent care? Are they going to the freestanding ER? Like,
So that is where we get the information about our program out there, so that they can still be referred to us. So regardless.
The education component, yeah.
So that's
Yeah.
so hard, right? We have to be able to measure it.
No, but
The physical activity, the data source is the survey, the behavior based survey.
That's not, yeah.
How many people answer the phone for that? So, you know, it has to be the data source, it has to come from somewhere, but that's where we get the information out, so we get the education and hopefully get referrals. So even if it's not me capturing this, you know.
In the data collection.
Yeah.
Very good. I like it. Well done.
Good Lord.
We're all working together, yeah. Well, you know, you guys have come a really long way from where we were 2 years ago when this was all a proposed measure to now, you know, really definitive action plans and, you know, resources being allocated to these issues. So, I continue to be overwhelmed by that and how impressive you guys have all been with all of this. So, yeah.
Plan for January will be to bring some requests for proposals. So we're going to, our position will be very specific in all the requests. So we're requesting for people to submit ideas for funding from this value to this value to these types of programs. And so that's what we will hope to do to expand our programs to meet the KPIs and beyond what we've already done.
So I just, real quick, and I know that I'm getting on a soapbox and I apologize, but for the asthma action plan, this is a very important piece of information. I find that a lot of my asthma patients, not my non-asthma patients that I'm newly diagnosed, but my actual asthma patients, do not understand that the goal of treatment is to prevent asthma attacks versus react to asthma attacks. This is a huge misunderstanding of the asthma population. So this should be a focus of that education. As it's not populace already. Perfect.
Yeah, that's what the program is all about.
Beautiful.
It's all about preventing and.
Perfect.
the least amount of albuterol use as
Right.
possible.
Yeah, because I mean, they'll sit there and pop on there
Oh, yeah.
40 times a day because
Yeah.
that's completely normal.
Yeah.
I
got better. The zips, I call it the zips.
We're all good.
Well, thank you again. Thank you for all of your hard work, and we look forward to working with you and moving forward on all of these and adding more. And I like this presentation of asking for how we want to direct where our funding will go instead of like just wide open, so that we are now being more actionable in terms of where we want to direct the increased funding to. So thank you. So next up, miscellaneous special recognition. Today, Miss Kathy Lemon, this will be her last meeting with us. She is not seeking reappointment unfortunately, after over 2 decades of serving us here on the Porter County Board.
As well as we can figure out.
Yeah, so, yeah, the data collection was a little sketchy back then. So we would like to recognize you and thank you for such a commendable
Oh,
level of service. I know that Demetrius has done like an interview, and there's a write-up somewhere. You have it?
yeah.
That they wrote up that should be dispersed on social media and email form about Kathy, and I know Terry has a few words to share with us.
I do. I have to read it, but it's
Oh, yeah.
not hard. You just have to read it. So someone once said, and I think it may have been my mother, that there are 3 things in human life that are really important. The first thing is to be kind. The second thing is to be kind. And the third thing is to be kind. Your kindness and empathy make a profound difference in the lives you have served throughout your career as a registered nurse for so long, and then notably here as a member of our Porter County Health Department for more than 20 years. It's amazing. It's quite an accomplishment, and we've seen a lot. To quote Martin Luther King Jr., everyone can be great because everyone can serve. And I have that hanging in my office for probably close to 30 years. It's important. I think we exhibit that here, and you've done a great job exhibiting that throughout this career. So thank you for your dedication and your compassion. Thank you for your unwavering commitment to public health. You've been a mentor to me, and you've been a pillar of support during the challenging times for all of us. We will miss you.
It's hard. I can't even imagine you not being here. I don't like.
I have to tell you, the picture, my daughter's right next to me. And to me, family is first. And this is family. It's just a different kind of family.
Yes.
So it's been,
What are you gonna do on the first 2
Yeah.
you know,
You're going to be a homemaker
Sit
somewhere.
there.
Yeah. I thought about it.
you know, it's a gradual weaning. You might see me in the audience.
Not to complain.
I don't
Only
know.
45 minutes of meeting.
Dr. Babcock would come by the office. But you were back.
It's hard to let go.
One evening out of the month. And
That's right.
For me, I'm retired. I have just about every day free. Your time will come, but don't rush it.
No.
No.
Thank you, Ken.
Oh, thank you all. I appreciate the kind words, and certainly didn't have to be, but thank you.
You deserve it. So we'll move on to our public comment section. If anyone in our audience has any desire for public comment. I'm sorry to have my back to you all the time. If the answer is no, then we will take a motion to adjourn our last meeting of 2024.
Oh, yes, I move we adjourn. All in favor? Aye.
Here, there you go. As she said, yes, thank you, thank you.